Thank you. And we're going to go ahead and get started. So welcome everybody. And thank you so much for joining us today to learn more about how to educate physicians and providers about value-based care models. So this is the fourth webinar of our five-part series. And as you just heard, the webinar today is being recorded. And as always, it will be posted on our website and shared back with everybody. We also today, Patricia will be putting a PDF of the presentation into the chat box. So if you want to pull that up, or if you're not able to visually see the screen, that's a great way to pull that up and you can go through it while Eric's going through the slides. I am Kate. Most of you, I think I know that I see on here already. I'm a program manager with the National Rural Health Resource Center, which is providing this webinar today through the Delta Region Community Health Systems Development Program. And as a reminder, the Delta program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. We love to see faces, so if you are willing and able, we would like it if you could connect your video feature. And I know you all know how to do that by finding that camera icon down in the lower left corner of your screen. As you join on, your audio, as always, is muted by default, and that just really helps all of us avoid background noise and feedback. We ask that you remain muted unless you have a question for Eric. To unmute your line, just select the microphone icon in the lower left corner of your screen. And you can also put any questions or comments that you have into that chat box. Next slide, please, Patricia. So just before we get started on today's webinar, I just wanted to give you a reminder of the last webinar in our value-based care series, and that will be on Thursday, June 3rd. And the topic for that one will be best practices to work with community partners on population health initiatives. The speaker for that session will be Tony Ann Richard from the Healthcare Collaborative of Rural Missouri. Next slide. And then we have two pre-polling questions that we would like you to answer before we get started on today's session. So Patricia, please pull up the first polling question. I am blank in my understanding of the key strategies that support the hospital's transition from the current payment and care delivery models to the population-based health system. We'll give everybody just another 5 to 7 seconds. Okay, Patricia, if you want to pull up the results. We have 50% responded somewhat confident, 31% neutral, 6% somewhat unconfident, and 13% unconfident. Okay, Patricia, if you can pull up the second poll question. I am blank in my understanding of various tools to gain physician buy-in for value-based care. Again, we'll give you another 5 to 7 seconds to fill that one out, and Patricia will then pull up the results. And on this one, we have 18% ring in at somewhat confident, 47% neutral, 12% somewhat unconfident, and 24% unconfident. Good information before Eric gets started here. Next slide, please. And there's Eric. In this session, participants are going to learn how to educate physicians and providers about value-based care. And it is my pleasure to introduce today's presenter, Eric Schell from Stroudwater Associates. I believe probably everybody knows Eric in some capacity, whether or not he has been your consultant for a financial operational assessment or for different activities that you've done, maybe through the Delta program or other programs that you have been privy to in the past. But Eric is a leader in supporting rural healthcare through the industry's transition to population health. And as healthcare moves away from fee-for-service reimbursement and toward payment for value, Eric and his team at Stroudwater provide vital financial and operational improvement services to ensure that rural hospitals and rural healthcare organizations continue to provide local, high-quality, and accessible patient care. We also have Joanne MG with us today, and Joanne is the CEO of Sparta Community Hospital, and Sparta is a member of cohort 2019 in the Delta program. She is joining us today to share her experience with physician contracting. So with that, I'm going to be quiet and I'm going to turn things over to Mr. Schell to get us started.
Thanks, Kate. Good morning, everyone. Good afternoon to me. It's good to see some familiar faces there on the screen and some faces, but we got a lot to cover here in a very short time, and so why don't we jump right in? This is there's four key pieces we want to get out in this presentation. The first is, it builds on what Dr. McKinney was talking about 2 weeks ago. Build the case for value-based payment away from fee-for-service. To set the stage for why we have to think about doing things different with our providers. The second one is to talk about how we think that actually value-based payment is a really good thing for rural hospitals, and frankly, demonstrating the value of having a strong alignment between you and your primary care providers. The third piece is especially go through this transition and how rural hospitals, key tactics that rural hospitals should kind of implement as we transition across this shaky bridge of healthcare payment transformation. And one of those is going to be around alignment with your primary care, which we believe is probably one of the most important element at this point. And then the third is really talk about specific alignment strategies and approaches for working with your providers. So 4 parts. Many of you have heard pieces of this presentation. What's a presentation from Eric Shell without the shaky bridge? And it starts right off there. There's a shaky bridge going across your picture. The goal here for me is to complete in about 45 minutes to give Joanne Angie some time. In my work with Joanne, she is, going back 10 years, she has had the most innovative and forward-looking physician and provider contracts that I have seen. And so to hear from her a little bit about how she's pulled together her contracts, her thinking is going to be absolutely valuable to all of you. So we got to clear the deck, get me out of the way so we can hear from the real pro. So with that, let's just jump into the presentation. We got about 30 slides and not much time to get there. I'm going to jump to the next slide. There we go. So again, this is the first part of the presentation around building the case for a transformation of fee-for-service to value-based payment. And I think the new CMMI director, Dr. Liz Fowler, talked about it in her first bullet where she says we can't have we need to find a way to bring everyone along. We can't have fee-for-service remain a comfortable place to stay. And it's like, okay, but why is this fee-for-service the enemy all of a sudden? And I look at it as if you think about the fundamental incentives in a fee-for-service payment system, it's around getting higher price per unit of service generated and providing higher units of sick care. Nothing in there is around health care. The incentives are just not there. And so the goal, maximize price, get paid more, maximize sick care utilization. That's how we're successful in fee-for-service. And the result has been we've got a lot more sick care at higher price, which has led now to our family premiums, health insurance premiums reported by the Kaiser Family Foundation of close to $24,000, a third of median household income. So I think the incentives inherent in a fee-for-sick care payment system are what we have to make uncomfortable and an uncomfortable place to stay. And CMMI has continued the direction of the prior administration in there. Next slide. Along with Dr. Fowler, the MedPAC and what MedPAC is recommending to Congress. I mean, ultimately, they have in their June report from a year ago, they talked about that in the first bullet, the Commission outlines a multi-year effort to lay out a strategic direction for Medicare payment policy and broaden the use of value-based payment. In the second bullet, they talk about increasing the ACOs, frankly, as a vehicle to move towards value-based payment. So here's how we're talking. Medicare, MedPAC is advising Congress around accelerating the use of building risk into ACO agreements, with ACOs being the payment system. So so that was a year ago. MedPAC has been consistent. Their 2021 report had similar. Well, actually, it's due out, but you'll see that I'm sure there's going to be similar findings when it comes out in a couple weeks. but clearly their direction. Next slide. And so, we believe, and in my longer presentations, I've got another 20 minutes of facts to justify that this fee-for-service world is literally going to go away over time. And it may take 10 years to go away, but it's going to transition to value-based payment. And we'll talk a little bit about the incentives in value-based payment systems are 180 degrees from the incentives within fee-for-service. We've got to continue to improve our operational efficiencies as we go through this transition. And clinical integration, this is where we start to talk about aligning with providers, is where we're going to create advantages to systems of accountable care. And obviously, flexibility is going to be ingrained into any of the short-term and medium strategies that we implement. So this is kind of where we are right now. Next slide. Next slide. There we go. Thank you. So, let's think about, if value-based payment, and Dr. McKinney talked about this 2 weeks ago, where he talked about patient value is going to be the kind of the driving force behind, kind of health systems to maximize value. And they talk about patient value as anything that improves quality, reduce cost, and applied to a larger population is a patient value, motivator or increase. It increases patient value, is what I want to try to say. So really what we're looking at is improving quality, holding cost constant, keeping quality constant, reducing cost. Any of this maximizes this equation of patient value, which is going to be the competitive driver in the future. We like to think about accountable care and not necessarily ACO, but accountable care, maybe value-based payments as, let's be more specific, and it's where a mechanism where providers monetize. So providers benefit from the value derived from increasing quality in this equation above, reducing cost applied to a larger population. So think about that again. Accountable care as a payment system, right? Is a payment system that we believe is a stable platform in the future. Providers benefit. They are the ones that benefit when the value derived from increasing quality, reducing cost, and applied to a larger population. And right now, there's all types of examples of these value or accountable care type payment systems. And in the bullet below, we talk about it. Bundled payments, value-based payment program. If you have your own self-insured health plan, you think about if you have a self-insured health plan, if you reduce the cost and improve the quality of your workforce, you benefit from that. You monetize that benefit. The Medicare ACOs, capitated provider-sponsored health plans, all of these are opportunities where providers monetize the value derived from increasing quality and reducing cost. And it's not managed care 101 like it was in 1992. It's very different. Accountable care as a payment system, we believe, is a stable platform for a number of different reasons. The first is it's that we got the incentives right this time. In the managed care area, think about who monetized the value of provider organizations increasing quality, reducing cost. It was the insurance companies. So the insurance companies had little to do with quality and cost. They had all the incentives to enhance the benefit from that formula. This time around, it's the provider organizations in the ACOs and the CMMI plans that are benefiting, and they have the greatest ability to affect quality and cost. So we got the incentives right. Government's all in this time. Remember back in the 90s, we did all of this gatekeeper and PMPMs and all of this stuff for 20% of our payer mix. Now we've got Medicare and Medicaid in most states all in on this thing. We've got new information systems to manage cost and quality. We have science to dictate care, clinical care. And frankly, going back is not an option. And at $24,000, the average insurance premium for a family insurance premium, we've gotten to the point where we've gotten so expensive, and as costs increase, there will be a substitutive effect. This is basic supply-demand economic theory, right? As price goes up, you have more supply, less demand. And the supply, our biggest threat right now in terms of supply is not the hospital next door to you. It's Amazon. It's Google. It's these huge tech companies that are coming in now. Amazon just announced, 2 or 3 weeks ago, that they've signed their first commercial company, Precor, I believe. It was just bought by Peloton, to a commercial contract where they're going to provide virtual primary care services to the employees of Precor. And they're looking for more. And it's all a virtual service. And so, again, as the cost of healthcare has increased almost in step function over the last 30 years, we've enabled this substitutive effect, and so we've got to figure this out. And we believe this accountable care payment system as a payment to drive new incentives is going to allow us to get back in a competitive position. Next slide. And so in this world, and this is one where the second part is about why I believe rural hospitals and rural health systems have incredible value in this new world of accountable care payment. And here's why. And it struck me back, almost 9 years ago now, when I was reading the ACO regs that came out back when the Obamacare was passed. And in the ACO regs, it said, it made a statement. It said, primary care physicians can belong to multiple ACOs. Primary care physicians can belong to one ACO. Hospitals and specialists can belong to multiple ACOs. And I was reading that as an accountant. My accountant mind said, oh my gosh, there's real value here for rural America. And the real value came from this. What it just told you is, if you think about incentives, right? How many times can you spread revenue around? You really can't. Revenue has to be aggregated. And so what it just said is that primary care physicians are your revenue centers in that new world. Expenses, you can cut up expenses anyway and distribute them. And so hospitals and technology and specialists all just became cost centers overnight. So, as I started thinking about that, rural hospitals with their tie-in to that primary care base are quickly becoming the revenue centers of this new world of value-based or accountable care payment, whereas the big city folks, the hospitals, the bricks and mortar, the technology and specialists are cost centers literally over the next 10 years. So rural hospitals that have strong alignment with their primary care providers, are efficient and have high quality, are invaluable in this new world. Next slide. And just to demonstrate that point a little bit further here, I want to compare and contrast the fee-for-service, the fee-for-sick care world that we live in today versus accountable care type payment models. If we think about fee-for-service, and this is volumes are on the x-axis, dollars are on the y-axis. If we think, let's just talk about revenue and cost to a hospital. Let's look at the cost line. It's the blue line, relatively shallow sloped line that says at zero volume, we still have to staff our emergency room, our nursing units, we have to have our minimum administrative staff, and at zero volumes, our costs start out really high. But for every incremental increase in patient volume, our costs go up a little bit. Think about that. You admit somebody to your hospital at noon today. How much did your costs go up? Not much. A couple $100 maybe, if that. On the other hand, your revenue line is much more steep sloped. We admit that patient today, and we get paid $1,800. So what happens is the steep sloped line, as long as we push out sick care volumes out to the right on the volumes axis, the steep slope of the revenue line will ultimately catch the shallow slope increase of the cost line. Thus, the goal is to push out volumes so the goal within the sick care payment system is kind of twofold. One is to push out sick care volume, because knowing that the steep sloped revenue line will catch this line. The second thing is to increase the slope, so push the slope of the revenue line to the left, which means you get paid more per unit of sick care service. And if we think about that, what's the best way to do that? Well, the urban hospitals have figured this out a long time ago. It's neurosurgery, it's cardiothoracic surgery, right? You get more per unit of service. And so, ultimately what's happened is the urban systems and the larger community hospitals have figured this out and maximized this world of fee-for-sick care. Rural hospitals, on the other hand, are a primary care-based delivery system, where for the most part, their units of sick care payment are a lot less than the big city hospitals. But now let's compare this to an accountable care payment system. We have our costs. Here's the revenue line. What is the key strategy to increase revenue in a accountable care or value-based payment system? Well, it's about accumulating lives, right? Patient lives. What's the best way to accumulate patient lives? Well, it's about patient attribution to primary care physicians. So if we think about that, if each busy primary care practice has an average of 2,000 patients in their panel, and the average per capita healthcare cost in the United States back a year ago was right around $10,000. One busy primary care practice has a value-based payment or accountable care payment value of 2,000 times 10,000. That number is $20 million. So a rural hospital that has 5 busy primary care practices affiliated with it or aligned with it has a value of $100 million for probably cost of $30 million. Rural hospitals in this new world of accountable care payment have a significant advantage to the extent we have aligned fully with our primary care providers. And again, we're building a case for this strong alignment with primary care. We've aligned with our primary care, and actually we're high quality and efficient. We win that game. Next slide. And so, I look at it and say, this new future, there's value in these rural hospitals and your rural health systems. Generally lower per beneficiary costs. We're in most part the revenue centers of the future because we are, in most cases, a primary care-based delivery system. And frankly, many of us are critical access hospitals, and that's a form of budget-based reimbursement, which, if you think about in today's Business 101, how do we provide kind of payment incentives to expense departments? Think about housekeeping. Frankly, we give them a budget, right? If you're going to be a cost center in the future, a cost center of today is housekeeping. How do we provide financial incentives for housekeeping? We give them a financial budget and we hold them to it. Well, frankly, because when hospitals become cost centers in the new world, we've got to start thinking about giving them budgets and holding them to it. And critical access hospital reimbursement is a step towards that. And so, again, value in rural communities. Next slide. And so what we've got to do, here's my favorite slide, don't anyone make fun of that. What we have to do is figure out if we have value in the world of 2034, where we have population-based accountable care payments, some type of payment tied to a population. We have value in that world in 2030. We lived in this world of fee-for-service payment on the left, the light gray shaded. And what we have to do is figure out how to get from the world in which we're the lost leaders to the world in which we have significant benefit over in 2034. Now, there's a couple of things that are, this graphic shows a whole lot of stuff going on. First of all, the fee-for-service payment. It was a stable pillar. It was a stable pillar of payment because we had a perfectly aligned payment system and delivery system. The more sick care that we did at higher price, the better we did. Over on the far right, we have a perfectly aligned payment and delivery system. The less sick care we do, the more health care we do, the better off we do financially. And everything in between is schizophrenia. And so the first question is, well, wait a minute, why don't we just stay in fee-for-service? Why do we have to move in this direction? Well, because what we've done in this fee-for-service world, as we've talked around previously, we've gotten the costs up to the point where we're so expensive that we've allowed significant competition from a whole lot of folks coming in, as we talked about, the Googles, the Amazons, all of those folks that are looking to come in here. So they're stripping volume out. The fee-for-service payment world lives in higher price and more units of sick care volume until we have new competition stripping out our volume, And we've got costs that are outpacing our price increases. And then this smolders, and we've got to step off it. When we start getting out here, we get into schizophrenia, because at some point, as fee-for-service payment systems are going down, as the new green, the population-based payment centers are coming in, you have a world in which you have schizophrenia, because you go to your providers and say, okay, half our payer mix is we have incentives to create health care, less sick care. We want you to really create a healthcare system. We got half our payment system that's fee-for-service. Let's go and blow and getting additional payment for more sick care. Your doctors and providers are going to look at you like you have three heads and ask you to leave their office. It's schizophrenia. And then the last thing is, well, why can't we just step from 2014 to 2034? And I would suggest there's two primary reasons. One is that we don't have a healthcare system. We have a sick care system. Everything we've developed in the last 30 years is around providing top-quality sick care with very limited focus and emphasis on improving the health of populations. So it's going to take us time to develop that. The second thing is the insurance companies, they don't want to give up on their fun ride that they've had for years and years and years. And so there's going to be dragging of the feet there until the provider organizations proactively pick up and take that residual claim on health away from the insurance companies. And that completely aligns incentives. So, to build on this, we're going to go back and forth. So let's jump to slide 15 and then be prepared to jump back. So Dr. Rajkumar actually defined these payments as we cross this shaky bridge. The first was this fee-for-service with no links to quality and value. That was that column that's 2014 that doesn't exist anymore. That is smoldering because of the competition around volume and our prices, our costs going up faster than price. So that's column one. The column two, this is the one probably just to the right of that 2014 category. Many of us are living in this world right now, in which there's fee-for-service, but now we're starting to see tie-ins and link to quality and value. If you think about it, we have the merit incentive payment system for physicians. They have incentives for improving quality, reducing costs. We have, we get paid for annual wellness visits, health-related activities. So we're starting to get paid for health. Category three, picture this category where your feet are right above the crocodiles. This is danger land. These are alternative payment models built on a fee-for-service architecture. And the reason why I think that this is danger land is that think about this as ACOs, where everything that we do to create health in our community, as long as we're still recognizing revenue based on claims, sick care claims, shows up very poorly, and our CEO and CFO get fired. The more we focus on increasing health when we're still built on this fee-for-service architecture is troubling, and it's a period you don't like to see with your feet right above the crocodiles. And then the last one is population-based payment. This is where you start to come away from the crocodiles and you move towards an infrastructure. I think of this world as no claims. Revenue is premium dollars, and where large systems decide to invest in sick care and health care resources is expenses. Claims go away in that world. And that world becomes stable. There is one health system in the United States that's figured this out. It's called Kaiser. And if you look at their quarterly reports, they've figured out how to price their premiums 10% less than everybody else to attract new lives, and then deliver health care at a 30% lower cost, because they consider themselves successful when their hospital beds are empty. I don't think there's another system in the United States that has figured this out like this. So anyway, that's the payment system. Let's move to the next slide. And this is I've got two more absolutely critical slides before we then set up this conversation around what we do and then aligning with providers. This slide, I think, really tells us what we're going to see going forward. I know I'm an accountant, so I like to focus on payment, but let's talk about why that is. First of all, if we go with the old premise that how we organize ourselves is meant to maximize the functional imperatives of the payment system that exists. So form follows function, follows payment. And if we agree with that, and now we start thinking about what are the functional imperatives of a fee-for-service payment system, with a payment system that currently exists primarily. And the functional imperatives are to increase price, increase sick care utilization, and reduce costs. And one organization competing with other organizations can do really well in this world as long as they kind of manage price, utilization, and cost. The form that evolved out of that payment system are independent organizations competing with other independent organizations on market share, right? That's what it was all about in the fee-for-service world. If we think about the new world of accountable care payment or value-based payment, you think about the functional imperatives. To be successful in a world in which payment is tied to a population, the first thing we got to think about is, can we do it as a critical access hospital in Southern Illinois alone? Absolutely not. We've got to have a medical staff. We have to have primary care. We have to have specialty care. We have to have tertiary care. We have to have public health. We have to have ambulance, post-acute care. All of these become pieces of managing the population of 20,000 people that surround our organization. The second thing is that we have to be able to accumulate lives to be able to diversify insurance risk, or this residual claim on health, which I'd like to call it, instead of insurance risk. I think insurance risk is a residual of claims. But we've got to accumulate lives. And let's say a minimum live count is 100,000 lives to diversify that insurance risk. And so those key functional imperatives, the form that has to come out of that is aligned organizations competing with other aligned organizations for quality and value. Again, we can't do it alone as a hospital to manage the entire health and sick care needs of an entire population. It's going to create aligned organizations competing with other aligned organizations. Next slide. So here's our approach, and many of you have seen like this in the past. And now I want to present it, but then kind of focus on a key area around primary care physician alignment. And so let me explain this, because we believe, and actually the center has agreed with us, that this is an approach where rural hospitals can move across that shaky bridge over time. So going across the top, you'll see that there's the light blue. It says fee-for-service, phase 1, phase 2, phase 3, and then the PDPS is provider-based payment systems. So fee-for-service, think about that shaky bridge graphic. The fee-for-service is the light gray stable column on the left, in which it is smoldering now. Phase 1, this is the payment system that probably exists for most of us today, where you have fee-for-service, but now tie-ins to quality and utilization control. Okay, so that's this phase 1 of payment. And it's probably going to be around for a couple more years before it starts to morphing into phase 2 of payment. Phase 2 of payment is the feet right above the crocodiles. It's not where you want to stay for very long. And it's this world of, we're starting to have alternative payment models, but built on this fee-for-service architecture. As we start to move to phase 3, now this might not be until 2030, but phase 3 is where we start to lift away from, or step away from the crocodiles and move towards alternative payment models built on an alternative payment model infrastructure. We look at revenue as premium dollar to big health systems, and expenses are investments in direct costs of investing in health care and sick care. In the end, we believe that the large systems, the provider-based health systems, are going to be where this has to go. We're seeing that now. I mean, Kaiser led the way. We've got folks like, UPMC out of Western Central Pennsylvania. We've got Geisinger. We've got Presbyterian Health System out of New Mexico. Intermountain Healthcare. We've got all of these systems that have created an insurance. Just recently, 2 weeks ago, UMass Health System in Worcester announced they just acquired an insurance organization so that they can move in this direction. So going across the top, measured in time, is the payment systems. There are 3 key areas that we have to kind of strategically address. And if you go down the left-hand axis, the first is the delivery system. This is the current sick care system that we live in today. We have to fundamentally transform this and proactively transform it. There are 3 initiatives to do that with. We have to, continuing to go down the y-axis, we have to create a health system right? We've been a sick care system for 50 years. We've got to create a health system, and we can't do it overnight. It's going to take time. And then going further down the y-axis, we have the payment. We have to pick up and move the payment system. Because if all of a sudden we create a healthcare system and we get our population 20% more healthy through exercise, diet, all of the things that we know improve health, if we stay in sick care, we're done. We're toast. And so each one of these, you know, the transformation of sick care, the creation of healthcare, and the transformation of payment has three core initiatives to kind of implement. The orange line coming down and coming up, this is the strike point. So when an initiative hits the orange line, we have to implement. Up until that point, it's a plan, and then even before that, it's a strategy to a plan to an implement. So let me just walk through this real quick, and then we're going to get into what do you do about it. So let's transform our sick care system first. So we're in phase one now. The first initiative, you can see the box has hit the orange bar. It's a strike point. We have to improve our operating efficiencies. We have to engage in quality and patient engagement. We got to do that today. The next one down, today in phase one of payment, is called primary care network alignment planning, to strike when the payment system gets out to that world of accountable care payments on a fee-for-service architecture. The reason why it's absolutely critical that we start the planning today to implement, a couple of years in the future, is because here's where your primary care becomes your revenue centers. This is your primary care base. Is your busy primary care practice with 2,000 patient lives in their panel is worth $20 million in this world. If we don't align with them, somebody else will. I don't know if you just saw, 2 weeks ago, Previa Health is this large aggregator of independent private practices, just did an IPO. They were looking to generate, $500 million. They went out, priced them at almost $800 million, significantly above what their initial expectation. And they have a big ACO to get independent private physicians in. So why is my phone beeping? Anyway, so primary care, significant. And service area rationalization, coming together with large systems to take out big chunks of fixed costs in the future. Most of those are specialist technology and bricks and mortar. And so the first three rows coming down are how we transform our sick care system. The blue bar in the middle is how we create a healthcare system. In the first box, phase one of payment, we don't want to go too fast here. We just want to create infrastructure, because if we get everybody healthy in phase one, our financial statements are destroyed. So patient-centered medical home, care management, data analytics, evidence protocols, building the building blocks of a population health system. As we start to move to the right, we start looking at payer network contracting, hotspotting, value attribution, the funds flow model. And think about this more from a high level of crawl in phase one of payment, walk in phase two, run and then sprint as we move all the way out. Around the transformation of payment, today, the strike point. If we have a self-funded health plan, have we designed the benefits so that we have incentives for employees to use our own facility? Have we created incentives? It's an at-risk population. Have we created incentives for health? Have we looked at the claims data? Do we understand what our employees are using? As we move up, transitional payment models. These are your low-risk ACOs. Start planning today to be in those, to fully implement. Full-risk cap plans, strategy, implementation plan, and strike sometime 2030 or beyond. So what we believe is this is a vehicle where organizations can take this nebulous concept of value-based payment, chop it up into bite-sized pieces that involves transformation of delivery, creation of healthcare, and transformation of payment, and keeping them in lockstep. So today we're in phase one. We should be checking the boxes on all 7 of these initiatives. As we get out to phase 2, we would already have checked the boxes on all 7 in the column 1, and now we've got new initiatives in phase 2, and so on. And so again, this breaks this thing all down. And thus, we believe this is the vehicle for rural hospitals to use to get from here where we are today to where we want to be in the future. Next slide. And so I'm just going to go through, but I'm going to spend specific time related to physician alignment because we believe fundamentally that that is right here in front of us. If we don't do this well, we're going to be on the outside looking in. So first is just, if you look in the top right-hand corner, we're going to highlight in the transition framework what box we're on. So the first is the strike point. We're there today because the payment system, we've closed 137 rural hospitals in the last 10 years because they haven't figured this out, is the payment system has moved. We've got to be more efficient. And efficient here is having appropriate sick care volume to meet need, revenue cycles, practices, operating. You got to be 45 days in AR and gross and net, expenses managed aggressively, physician practices managed effectively, and having an effective organizational design. Next slide. Quality. We have to, part of that is operational efficiency and quality and patient engagement. How do we compare? How does our organization compare to everybody else around us? We should be able to beat all other organizations. I give this example because these are HCAHPS scores. This is a critical access hospital. You see in the far left-hand column there, where the dark green means it's the highest score of all the hospitals that are listed. Light green means they're above the national averages, but not the best. The pink means you're below, and then the orange means you're the worst. This is a critical access hospital in Western Massachusetts that is operating. It's the core of the hospital is operating in a 1940s facility, an absolute dump. And I've told the CEO, I make fun of him all the time. It's an absolute dump, and they have the highest quality scores in the state of Massachusetts as a critical access hospital. We should be able to know where are we and are we at this level. Next slide. This is where we're going to start talking about primary care alignment, and I'm definitely spend 10 minutes or so in this area. At this point, we're the second row down in the transition framework. And again, I fear for the critical access hospitals and the rural hospitals that we don't have the alignment that we have necessary to overcome the strength of the economics as they play out. And what I mean here is the value of primary care practices rise as we move to more and more of these accountable care payment systems. The forces for others to come in and take them are going to significantly increase. $20 million to you or to somebody else, at this point means a whole lot more than to you because until we understand that. And so the first important thing, this bullet, understand that those future streams of revenue are tied to primary care providers. And the extent we all walk out of here with that fundamental understanding that the revenue centers in the new world are primary care and put a dollar amount on them and say what we've got to do is use that information to ensure that our alignment is as strong as we could possibly do. We think about, your medical staff right now. Using Stephen Covey and his models of dependency, he talks about dependent, your 5-year-old, independent, your 18-year-old, and interdependent, your 26-year-old. I don't have one of those yet. I know it's going to be better than the 18-year-old. And so what we have to, I think, recognize is that your medical staff and your primary care doctors, they're fundamentally independent. If you were to fire them today, they would have a job before you hung up the phone with them, which means they're fundamentally independent. There is such a demand for good primary care, whether it be independent practices or Previa Health or any of these companies. And because of that, we've got to really standardize our alignment approaches. And we think about this alignment, a three-legged stool of contractual alignment, functional alignment, and governance. Contracts, this is the contractual alignment, employment agreements, and we're going to spend some time talking about employment agreements, management agreements, other things. Anywhere where we can put a contract in place with these $20 million revenue centers of the new world, we seek that out. Functional, how involved are they in developing evidence-based protocols in our hospitals? Do we share medical records? What is all of that? both with, even the independents. What is our opportunity to share medical records? And governance. Where is our medical staff in executive leadership, in planning, in board? All of these are opportunities. And that three-legged stool of contract, function, and governance is absolutely critical to strengthen that alignment with your primary care base. And some hospitals say, well, hey, all of my primary care providers in our community are independent. They don't want to be employed. There are other opportunities to focus on this contract, function, and governance. One of them is, a PHO, a clinically integrated network, an integrated health network. All of these are opportunities for contractual, functional, and governance alignment. And I do want to make a statement that's saying, just because you're employed does not mean you're aligned, and just because you're independent does not mean you're not aligned. So, that's a really important statement, because you could say, well, the independent, you could have your independent doctors be more aligned with you than your employed. The key is, through this three-legged stool of function, governance, and contracts, is to strengthen that for all of the providers in your community. Next slide. So there's lots of levels of kind of this contractual piece of alignment, where you go from least aligned, where you have independence, private practice. And when you have that, if we want to seek out that contractual relationship, right, we got to seek to do things around the integrated health network, or clinically integrated network, or PHO. We have medical directorships, joint ventures, co-management, the PSAs, the MSAs, and then to full employment. These are all opportunities to increase the scale around, that contractual piece, from being least aligned to most aligned. So here are some, opportunities to move the curve from the left to the right in terms of advancing those relationships with your doctors. Next slide. But, as we transition to the value, there's questions that we have to ask related to our providers. First of all, I think, based on some of this presentation, and I'm sure what you heard from Dr. McKinney last time, value-based payment is going to have this direct impact on how we compensate physicians and APPs. And I think one of the reasons why Joanne from Sparta is going to be talking is she's done a great job of incorporating in. They've looked at value-based payment, incorporated a lot into their contracts. Where's the organization going as it transitions to value? We strongly advocate for rural hospitals to be moving in this direction. One, because we add value, but two, because the fee-for-service world is not here for long. Where is our organization in the compensation model? And again, I'm looking forward to hearing from Joanne, because she's done a really nice job. And what do our physicians expect? Next slide. So here is the type of compensation, and Joanne will be able to speak to them. There's really four components of a good physician compensation model or contract, especially as we evolve from the world of fee-for-service to value-based payment. There's the four pieces. The first piece, top left-hand quadrant, starting base salary, it's annual guarantee. It's a base salary. And it should be adjusted on a regular basis to meet kind of market, where the market is. The next is a productivity incentive. I mean, frankly, you're saying, well, don't we want to do less sick care? Well, the way I look at it is primary care physicians, they get paid in denominations of tens. If we can invest in denominations of tens and reduce and have them invest in healthcare, getting paid in their practices, to reduce some of the hospitalizations, especially the hospitalizations to the urban communities that the referrals often end up at, it's a good thing. So we start off with a base compensation, and then we provide incentives for the doctors to work harder. Often work RVUs are an important part of that, and so generating this compensation for work RVU, and again, Joanne's got that built into her contract. She can talk about that. We start talking about, I'm going to go down to the 6 p.m. to 9 p.m. quadrant. Admin, administrative, and academic duties, to the extent that those are. medical directorship, APP supervision, faculty, any of this research, any of this stuff are opportunities around adding additional compensation to your providers, recognizing these duties. And the last one, the 3 p.m. to 6 p.m. quadrant, is value-based compensation. Have we gotten to the point around contingent compensation and holdbacks? I was with an IPA in Rochester, New York, where we had a 15% withhold on all our provider compensation. This was in the 90s with the whole managed care era. But I believe in the near term, well, maybe not in the near term, but in the medium term, we may be looking at those types of things. Value-based reimbursement, adjusted work RVU, patient panel management. I would like to see every physician compensation have some type of a panel size incentive built into it. And then ultimately distribution of ACO dollars. The extent that we've created savings within our value-based payment models, can we trickle that down to the grassroots of that being our primary care base? So types of compensation models right here. Next slide. And again, it's thinking about it as we move towards the future here in value-based payment. Increasingly we want to move to variable compensation with base salaries consistent. Current state, most of our contracts have this productivity incentives. We want to maintain those in the future. As we start to move out, a couple of years, quality incentives. And then, especially with the merit incentive payment systems if you're not in rural health clinics, and then ultimately at-risk performance, and as these roll out. So next slide. So a couple of years ago, my colleague and I pulled together what we see as the kind of as we start to roll out accountable care payment models, what do we want to see in a provider scorecard? And this was one of these brainstorming exercises. Many of you know Greg Wolf. He and I worked together on pulling this together. But here's how we started thinking about what a provider scorecard should look like. There should be incentives in this scorecard around health in the box at the top. Metrics focus on provider panel size, utilization, prevention, and health status. Data coming in from the EHR. And the PQRS reporting system, all something around health. The next thing is around cost and per member per month. And we think about in the future, there's kind of 3 buckets of cost. There's the in-network. In other words, if we can provide services in our hospital, in our direct health system, then if we can the next is, that's highest priority. The next priority is in-network. So within our network, in our health system that we've created with other regional providers, but not in our hospital. And then finally, out of network. And frankly, these become the most expensive. And if we start thinking about ACOs and budgets and things like that, the only time when an ACO, when your variable cost of producing any type of service is equal to the claims cost shown up in your ACO budget, is when you do out-of-network. If you're able to provide a service in your own network, the only true cost of it is the variable cost of that production. You've said there's significant benefit to this in-network relative to the out-of-network. There should be a quality dimension to the provider scorecard, and then ultimately a patient satisfaction. All keys to getting your relationships with your providers in line with your accountable care and future payment system strategy. Next slide. So we're just going to move down these quick, and then we're going to turn this over to Joanne. I think I've borrowed about 6 or 7 minutes of her time already, so I'm sure she's anxious to share her thoughts. So the next one, moving down, we're going to move down to row 3. This has to do with coming together with larger systems to ultimately take out big chunks of fixed costs in the future. Big chunks in the future are specialist technology and the big bricks and mortar, mostly in the big cities. So again, start to develop this system integration strategy, coming together. Think about those models of dependency that we talked about from Stephen Covey. Is there a way to move from independent? First of all, if you're losing a bunch of money, you're dependent. There's a hospital I'm working with right now that's losing $3 million a year, and they want to know their affiliation strategy. And I said, your affiliation strategy is to become independent first. Let's get you break even, and then you can have conversations from an independent to interdependent relationship. But, is there an opportunity around functional governance and contractual relationships that you don't have to give away the soul of the organization? Start looking at the providers in your service area. Is it the right count? And, so again, this is that second one. Next slide, please. So payment, how are we going to start to pick up movement payment, right? Because if we're creating health, if we're transforming sick care, if we don't move payment, we're in trouble. So today in column 1, our own self-funded employer health plan. We're already 100% at risk for our own employee population. And what do we have to do to take that population and create health and incentives? One, if they're going to be sick, use our own system. So greater consumerism. I've seen plans that create incentives around health status, BMI calculations, incentives for health in gym memberships, and all of these are investments you make in creating health within your population. What about all the types of fee-for-service quality and utilization incentives that currently exist? Inappropriate ER physicians, or the insurance companies that are paying now to keep people out of the emergency room, annual wellness visits, chronic care management, and any merit incentive payment system incentives that exist. Next slide. So the next is we start to move out the payment system, and we start to look at more transitional payment models, which include anywhere from fee-for-service against capitation benchmark with shared savings ACOs, prioritize the insurance market opportunities, explore direct contracting opportunities with self-funded employers. I have a client of mine in Louisiana. They actually have a direct contract with a local university where they provide for a PMPM access to all of their primary care clinics for the employees and students at the college. Interesting direct contract opportunity. Next slide. And the next slide is really around this building the infrastructure for healthcare, not going too fast. This is the crawl approach. Patient-centered medical homes, care management, develop claims analysis capabilities, evidence-based protocols. All of these are opportunities to develop infrastructure, but not move too fast in creating health. Next slide. And then we start to move out. Again, we'll hold off on getting into this presentation, but these are just some of the bullets around when we start to move out to columns 2 and 3, in creating that health system of the future. Next slide. And again, the transition framework, transformation. The x-axis is the payment systems evolving from fee-for-service on the left over time to fee-for-service with tie-ins to quality and utilization in phase 1, alternative payment models built on a fee-for-service architecture, feet above the Shaky bridge, phase 2, and then they advance down the y-axis. We have to transform our delivery system with the 3 initiatives identified. We have to create a health system with the blue bar in the middle, and we have to fundamentally pick up and transform payment with the 3 initiatives at the bottom. Next slide. And so, ultimately, for decades, rural hospitals have had challenges in the fee-for-service world. We believe that health, local, rural, and community hospitals have high value in the new world for their tie-in to the primary care-based delivery system that exists. Crossing the Shaky bridge is not for the faint of heart. It's going to require planned and proactive approaches, and the key is to maintain the lockstep between delivery system transformation, healthcare creation, and payment as we transition across that system. And making sure we build in flexibility because we don't know the timing of when this is going to play out. Next slide and last slide. So, the important strategies, obviously we got to increase leadership awareness of these new realities. Let's create a strategy to get across this bridge. And the one that I've highlighted is align, partner with medical staff members, contractually, functionally, and through governance where appropriate. I've laid out some of the things in this talk around some opportunities there, how to think about those opportunities. But I think if we walk away from this presentation with one thing, and that one thing is the value of our primary care base in the future, it will allow us to ask very different questions around the strength of our alignment and how critically important that is. So with that, I'm going to turn this back over to Kate, you, and to MC the ends of it. I don't know if we open it up for questions or we turn right to Joanne to provide her incredible commentary.
Yeah, before we get into the Q&A, let's turn things over to Joanne first.
Okay, thank you. I am Joanne MG. I'm CEO of Sparta Community Hospital. Actually, we are a tax district facility, independent, no formal affiliation with any larger system. We're located in Southern Illinois, about an hour outside of downtown Chicago. I have actually been CEO for 25 years. So, certainly there's, as not only myself, but my senior leadership team comes with a long tenure. And I'd like to think that adds trust to the organization and helps with that physician alignment. We have 9 active primary care physicians, and their tenure ranges from 5 to 40 years. Also have 10 non-physician providers and offer services in 5 rural health clinics in 4 different communities. When I came on board, actually, the physician contracts were basically a base salary with an incentive based on profitability of their clinics. So basically their base was set too high and they had no opportunity to really tap into that incentive. So over the next 5 years or so, started strategizing, how do we change that? Because unless your physicians are different than mine, they don't want a reduction in base and they don't want to be at risk. So it's taken us a long journey to get where we're at today, but throughout the years, we've seen continuous improvement. So we started about 20 years ago with planning our strategy and how to move those contracts. What we did know is we wanted to focus on improving operations. And also we had to be considerate about what we could sell in the first round because it was a whole new thought and what would they buy into. So actually about 2003, 2004, we rolled out our first agreement, which had incentive measures. And actually that was more performance-based operations. It had things such as, it did have a section on increasing the profitability of the practices. It had record completion, resource management to control staffing costs, pre-cert medical necessity, medical attendance, alternative appointment times. Those were the incentive measures. From there, actually, we moved, and of course, they've always had a worked RVU productivity incentive as well from that time. From there, we actually started moving from the performance incentives more to the quality. And actually, since about 2015, when we actually joined an ACO, we've been very focused on quality population health. Although, what gets monitored gets improved. And so we actually had to make sure that we didn't remove all of the performance, such as it took us a little while to remove the record completion. We still do have the meeting attendance because it's very important that they see a benefit in attending the meetings because ongoing communication, ongoing education is so important during this time. But currently our measures are based on our organizational goals. We have organizational goals that deal with patient satisfaction, panel size. So their goals are reflected on the CG CAP surveys specific to them as a provider. Their record completion actually has gone away. Meeting attendance has continued to be an incentive. Their panel size increase is a measurement, as well as alternative appointments, because it's very important to be able to improve the access to our patients. So that we also actually have quality measures such as the percentage of wellness visits, the percentage of their patients with diabetes with an A1C less than 9, their hypertensive patients that are controlled, as well as their percentage of mammograms being done. So we focus on those measures because, as I shared, they stem down from our organizational goals. We actually have the ability to adjust those measures every year by just written notice. So as we tweak and change our organizational goals, then that changes not only possibly their measure, but also resets the goal according to where we end the year. Throughout the past 6 years, it has been a learning process with the ACO, but we talk about it all the time. And not only with the providers, but through town hall meetings and through the goals cascading, not only from organizational goals to the providers, but all through the different levels of staffing. And as Eric shared, it's not only our employment doesn't assure alignment. I think what assures alignment is relationships. So the fact that we do have a longevity and the trust in our senior leadership certainly adds to that alignment. But I tell you, I like to work with independents. Now, we don't have any independents outside of our specialty groups, but they get it. They know, and they get the reimbursement side. Where from the employed side, a lot of times they're tuned out to all those changes. They don't know because it's not affecting them. So we have to continue to talk about it. Every meeting we address. So I guess words of caution or advice are, as you start to change and move to the quality measures, move slowly, communicate, hear them out, and have some flexibility. They have to understand the why, and they have to understand their data. You have to be able to show them where they're at and where the new plan's going to take them. Our current opportunity is with the 2021 physician fee schedule. Because as we looked at the end of the year when that came out, we knew we were going to have a significant bump in their worked RVU production. And so for doing the same amount of work, we didn't want them to actually automatically achieve an incentive for the same amount of work. So went to the providers, and they, of course, all agreed to stick with the 2020 physician fee schedule. And as we found, there was about a 20% bump in those work RVU values from the 2020 to the 2021. So now we're in the process of resetting those worked RVU thresholds and actually going to those providers, having them buy in and understand why those thresholds are changing. So as we work towards shared savings, we have to look at how will that be shared back with those providers. But we picked these quality incentive measures that we did because we didn't want to only focus on the ACO panel. We want to focus on our total panel of patients. And as we work with the other payers, whether it be Blue Cross or the Medicaid MCOs, we use those defined measures. So they're all looking at the same thing. So it's not only the ACO population, we measure across our entire panel of patients. So, Eric, what did I miss, or what would you like me to cover that maybe I haven't covered?
Joanne, could you speak to, in your perception, the level of alignment you have with your primary care base? Do you feel that from that governance, contractual, and functional, that you guys are all rowing in the same direction?
Sure, I think we are. From the functional standpoint, we have tried to remove from the offices things that can be maybe better handled in a centralized fashion, whether that be an intake department from a call center, whether that be from pre-certification. referral management. We try to bring billing and coding. We try to do all that from a centralized location to allow them to practice medicine. You know, because they don't have control over a lot of that. They don't have control over insurances. All they have control over is seeing the patient and hitting those quality measures.
How
So
engaged
certainly from that function standpoint, I feel we're aligned, you know, from the contractual alignment as well, I think. And, you know, they trust that if it's not working, we're going to fix it. We're going to fix it so it works. So they're not, don't feel, they feel that they're locked into anything forever, because we continuously are looking at how to do it better.
What about the governance piece? Do you have elements of your medical staff participating in your leadership council or your board, or how's that?
Well, there is restrictions on involvement at the board level because of the conflict of being employed. So they don't, but our chief of staff actually comes to every board member, every board meeting, and actually presents a report. And if there's information we need to gain from that individual, certainly that opportunity is there. We also have a joint conference where the chief of staff and the past chief of staff meet with two members of the board on a quality time frame. We also have the different committees with the chairs that are very active. So I think certainly they are involved in governance, even though they don't basically sit on the board of directors.
Right on. Well, how involved are they in the alternative payment models? In terms of, are they interested in, you know, are they doing things around creating health within their patient panels? I mean, how is that going right now?
Yeah. Well, actually, they are very involved at looking at our avoidable ERs and looking at those bounce back patients, as we call them, because we review all of those monthly if they're admitted and bounce back to ER, or we review those. Current project that's underway is we identified that our top avoidable ER visits were dialysis patients. Now, we recognize we cannot do anything about the dialysis, but we're currently working on what can we do to prevent those avoidable ER visits. And then what can we do from a care pathway to help prevent dialysis? How can we recognize those renal diseases early and put care into place to make sure that we can avoid dialysis if at all possible? So that's just an example.
I have to tell you guys that Joanne and what she's done with her team around the physician contracting and alignment are probably the best practices I've seen in all the hospitals I've traveled to. So I hate to put Joanne on the spot, but if you guys have any questions there, Joanne's a great resource to reach out to. So Kate, let me turn it back over to you, because I think we're down to about 2 minutes, which
we are, yeah. And thank you so much, both Joanne and Eric, for presenting today. And I'm going to multitask here a little bit. We have 3 post-polling questions, but we also have some questions in the chat box. So Patricia's going to pull up those post-poll questions. If you guys could please just take a second to answer each one of those as she pulls them up, that'd be great. And then Eric, to you, we had a question from Chris Davis. What effects do you think the new Medicare payment structure will have on rural health value-based care, more specifically to our rural all-inclusive Medicare rate?
Ooh, Chris, what? I'm not sure which Medicare piece you're referring to.
And Chris, if you want to clarify, you can come off mute.
Hey, Eric, can you hear me?
Oh, yeah. Hey, Chris.
Hey, Eric, this is Chris at DeSoto Regional. So as you know, the all-inclusive or the Medicare rate has been capped, especially for provider-based rural healthcare clinics. And in the past, when we were in our ACO, we did very well with it, but there is a lot of expense that's as in a rural healthcare clinic that you have to get FTEs, you have to do a lot of different things, and expense normally you can get reimbursed through your all-inclusive rate on, or pick it up on your cost report. With all of these different things, are with that payment changing, how do you you think, how a lot of the rural healthcare clinics are going to be able to afford the expenses that comes along with value-based.
Yeah. Well, a couple things. So what Chris is referring to is the Consolidated Appropriation Act that capped the provider-based rural health clinic rates at your 2020 rate, then trended forward with medical inflation. And the fact that we have to make some investments in our rural health clinics to staff up for some of these value-based pieces. So, and how are we going to do that? First is a couple answers. One is that there are new payment systems, the chronic care management that's paid over and above your all-inclusive rate, the annual wellness, well, the annual wellness visits are not. But so there, look for new ways to get paid for some of that health-related activity. The second thing I would say is that most of you, your 2020 rate is going to be artificially high. That's your base year rate because your utilization during a pandemic for your rural health clinics was low. So what that means is if your cost stayed constant and your utilization was cut by 20%, your rate is inflated significantly. Your base year rate is significantly. So you have room to slide additional costs in and still be able to stay under that 2020 rate inflated. Chris, I hope I hit on, a quarter of the question that you asked.
You did. Thank you.
Okay.
Great, thanks, Eric. Yeah, and we do have one more from Douglas Tanner at Grove Hill. So he said, yeah, we're in discussions with Caravan Health about participating in one of their collaborative ACOs. However, the agreements are extremely complex and beyond the expertise of our retained legal counsel. At the same time, we don't have the internal financial analytical horsepower to fully understand what we may be getting into. Given that many of our peer rural hospitals would face the same hurdles, how would you advise a rural to move in this direction with confidence and eyes wide open?
Yeah, good point. A couple of responses to that. First is, we're making the assumption that staying in a fee-for-service is risk-free. And I would say that that's not the case. Staying in the fee-for-service with the new competition that we're seeing and the challenges of increased payment relative to faster rising costs, that smoldering of that first column, right? So there's a cost associated with staying status quo. The second thing is I've been a fan. I've been a proponent of Caravan, ever since the business model came out, where it's a model where we could start to move towards kind of playing in this world of population-based payment. Years ago, Dr. Clint McKinney, he made the statement, and he said, you do an ACO for the data alone. You get access to the claims data. And what the experience of the Caravan hospitals is they're actually able to increase the utilization in their own hospitals and then also create shared savings from the away hospitals. In other words, they're using the data to say, hey, there's patients that are going out of our network that could stay in. Let's sit down and have those conversations, which drives up sick care utilization in the short term, and while at the same time increasing, reducing your ACO spend from the referrals to the big cities. So, Doug, I know there's a lot of detail and sophistication, and maybe you could get Lynn to get her people to explain that a little bit better. But overall, I'm a big fan of moving towards the Caravan ACO or any other regional ACO to the extent that they're out there and working.
Great, thank you. And that was all the questions that we had in the chat box. And I know we're over on time, so I appreciate everybody staying. Thank you again, Eric and Joanne, for your time today. And also thank you to all the Delta program participants for joining us. I hope everybody has found this session beneficial. We have one final session next week at the same time. And if you have any questions, be sure to reach out to us or to Eric. His contact information is right here on the last slide as well. So everyone have a great day. Thank you again.
Bye all.
Bye-bye. Thank you.
Bye.